we might not see each other for another 3 months. I might see you in 3 months' time and you'll be like, Donnie, you look thinner. Must be the GLPs, right? Like, we're going to have this perception going on now of people like, did he try hard or is he on the drug?
Tell me about a GLP-1 antagonist.
Yes. So there are GLP receptors in your gut, in your brain, in your muscle, in your livers. These GLP antagonists block that GLP pathway, to put it as simple as that. What that does, for example, in your brain, it increases satiety, decreases your appetite. In your gut, and this is how lots of people...
Did we have GLP-1 receptors like 5,000 years ago?
I'm going to say yes. We just didn't figure them out then. Yeah.
No, we just hadn't activated them.
Yeah. So that works in your brain. In your gut, it delays gastric emptying. This is how lots of people interpret how this drug works. Works in your muscles in terms of how you metabolize or use your sugars. So they're in various places. Modern science has just tapped into how we can block them and use them more efficiently.
So we're blocking out the noise rather than making you feel less hungry.
We're doing both. And I think these drugs in your brain, it will work on blocking out the noise. So you don't have that food noise. You're not thinking about it all the time. You get fuller, easier, both physically and psychologically. Because, this is the thing with abundance, right? And I've been guilty of this so many times. We are physically full, but we are not brain full. I mean, we've done this many times, right? Like that extra slice of cake, that extra biscuit, you didn't need it. But you went there because your mind wanted it. So it blocks out that as well.
We spoke a bit about, and you've done some work in when it comes to people and how they feel about themselves. Right?
Yes.
Is it not a case also that they're trying to fill their stomachs and fill their lives in a way?
Yes.
So isn't it as much a case that the drug may treat the obesity, but the drug hasn't helped you and how you feel about yourself, why you need food all the time, why you need sweet things all the time? Isn't there something missing, as it were?
So quite interesting. When I went to the launch of one of these products, there was a speaker that said these drugs are disease-modifying drugs. They're going to make you more functional and they're going to make you healthier, but they're not going to make you necessarily thinner or happier. And I think that speaks to a totally different pathology that we have in 2025. I think the world's in a mental health crisis, and I think we try and substitute this with food, Instagram, social media, dopamine hits because our brains crave dopamine. And I think that speaks to a totally different problem as well, that we need to do better when managing our mental health.
But did we have as many obese people 50 years ago?
No, we didn't. And if you look at the statistics, I think there's 1 billion people in the world that are obese now. The projection is by 2030, which is 4.5 years from now, we'll have 3 billion people that are obese. So it is rapidly out of control.
Tell me about GIP, gastrointestinal polypeptides, which are also included in Mounjaro, even though Mounjaro is not a weight loss drug.
So I think we need to speak. So there's a lot of these drugs that are marketed under the umbrella of GLP-1 antagonists or weight loss drugs. Mounjaro is a combination of a GLP-1 antagonist and a GIP, meaning it works on 2 different pathways, but that drug is only indicated for diabetes.
But having said that, Ozempic also started out that way.
Yes. So it comes down to registration.
And Wegovy's got double the semaglutide.
So semaglutide is Ozempic, and that's how it started, and then they've changed the registration. Mounjaro, back to the GIP, works on 2 different pathways to help manage your diabetes, and with that, you'll lose weight. So diabetic drugs versus weight loss drugs, and there needs to be a differentiation between the 2. And it comes down to what the registration at SALPRA is.
How do we manage the medical fraternity now?
That's a very good question, actually. Like, we as doctors need to do well in the type of patients we put on this.
Because I've got a patient, right? And they're borderline obese.
Yeah.
They're on that edge. They're 29 and a half. But hey, the person wants, he can pay for it.
Yeah.
She can pay for it. I may as well dispense it. I mean, maybe it's 28 and a half. Maybe even 27 and a half.
I'm going to take this even one step back. Every doctor's got a patient, but every doctor's got a friend as well, right? That's going to be nagging. Maybe even a partner, maybe even a child, like dad, mom.
Or someone who's diabetic and can sell it off to their buddies.
Yeah, so these things always happen, but we need to follow good clinical practice and good clinical guidelines. And you're right, doctors need to draw the line in the sand where they're like, no, I'm not going to let my wife, who's got a BMI of 26, but is nagging me for it because she wants to be in a bikini in Brazil on this summer holiday. That we shouldn't do. Good clinical practice, good clinical guidelines.
Because I think about it, I'm thinking about, as I say, the blue pill, the opioid crisis. Now you've got this, right?
Yeah.
So I don't know if you know, there's a song called In the Year 2525.
We're there now.
Right.
Who sings it?
God, it was a number one hit in 69. But the thing about, in part of the song, it did say there'll be a pill for everything, basically.
Yeah.
Right? We've kind of seen that, right? But the effects have, well, I mean, maybe not in the case of the blue pill, but certainly in the case of opioids, it's not been good.
It's not been good.
I worry about the side effects in 5 to 10 years' time. Is it going to take us that long to know?
So these drugs are not been around since yesterday. If you look at GLPs as a class of drugs, they've been around for about 30 years.
Right.
If you look at liraglutide, which was the precursor, that came out onto market, I think, in 2010. Semaglutide has been around since 2017, and there's a lot of studies that have backed up this evidence. So I read something that they've got 33 million patient years worth of evidence on semaglutide. What that means is one patient year is one patient monitored on this medication for 1 year. So you can take that as 3 million patients watched over a year. So they've got studies and numbers to back that up. So that's quite a big confidence interval. So I think due diligence has been done. But as I said again, for the right person with the right indication.
Zager and Evans.
Is that who sang the song?
That's who sang the song. Before someone trolls me. But we spoke earlier about the messaging about food. The messaging around cigarettes in the 60s and 70s was very different.
No, it was, I mean, I remember in the 90s when I was in school, they used to have these parties, right, where you would go there and get given cigarettes.
I traveled overseas in the 80s. You could smoke in the plane.
Oh, wow.
So, now vaping is the cool thing. If we bring out laws about vaping and we turn down that messaging and up the health messaging, we'll probably see the same outcome. Why can't we do that when it comes to food?
Good point. And I think we've always treated this as more benign because, eating doesn't cause lung cancer like smoking does, but it causes cardiovascular disease. Maybe even worse, right?
Yeah, exactly.
Maybe even worse. And I don't know. I think we should definitely, all I can do is take care of what I'm responsible for, and that's upping the education, upping the health message. How big food brands, you've often heard these stories of like, they just pump messaging upon messaging upon messaging. I mean, and I don't think these apps help as well. You get these messages every day, 2-for-1 deal on a delivery app. We really need to do better. And especially to this adolescent group. As adults, maybe we can make better choices. But if you look at 27% adolescent obesity in South Africa, kids are vulnerable to this. And we never had those alarming statistics when we were growing up. So we can't have these obese children turn into very obese adults. And you're right, it's not just a drug that fixes this. It's lifestyle changes. It's how we messaging around food. All of these things play very important roles. These medications aren't just a silver bullet that changes everything. You've got to look at it as a whole, comprehensive.
I come to your surgery and I say, I think I need to lose weight. I'm not obese, but I've looked at some of these, I've had my bloods done and everything. And let's just be honest, I'm not looking good. I'm going in the wrong direction here. Can I get some of these drugs, please?
And I'm going to say this to you and be like, we're going to do your bloods. We're going to look at that numbers. We're going to stratify your risk, see how at risk you are.
No, but I really want these tablets.
And we're going to stage in the necessary, correct clinical practice intervention. And there are different, based on your risk stratification, there are different modalities.
But there's a suit I want to fit into.
And this is where doctors should not be pressurized into doing the wrong thing. It should be done in the right way.
I think it's going to be difficult.
It's going to be very difficult. It's been very difficult. I mean, when the first one of these drugs came out, we were put under huge pressure by people. I saw so many people would phone me on my phone that, we won't mention names, that are size very small, extra small. And they were like, I want to be XXS. I need this drug. And I'm like, no. Then they'll be like, well, if you're not going to give it to me, I'll find it somewhere else. And this is the pressure that physicians are going to be under. we've seen bad examples in the past. You're a big music person. Michael Jackson. You
Sure.
see what happens when doctors do the wrong thing and give medication to people. We don't want class action lawsuits. We don't want things to happen with propofol like it did to Michael Jackson. We
Sure.
need responsible prescribing
But we spoke
physicians.
earlier about, the compounding pharmacies in the US. What happens as a doctor when you think that person's going to leave my surgery, I haven't changed their mind, and they're going to go and get a product that isn't the real deal and
Yeah.
also has not been prescribed by a professional.
And back to your point, with those laxities, from what I understand in America, this is how we had the opioid crisis. When doctors were like, they got incentives from patients, from companies, from everyone to continue prescribing this drug. This is how we end up with the bad effects of a drug. If we just hold our own and hold the line, I think we have the patient's best interest at heart and can do that. And we really need to counsel them appropriately. But we also need the support from governing bodies like SAPRA that really crack down on counterfeit medication.
Because again, I go back to the blue pill. It becomes more part of a cultural understanding than someone who's got another chronic disease, right? And I think that's where we're going with these drugs. They're going to become part of the cultural parlance.
Yeah, it's already there. You go to coffee shops here. I've heard patients tell me this of like, "Are you on the drug? Are you on the drug?"
Right.
Like, and we already starting this perception of like,
No, I've seen articles about Katy Perry, for example.
I mean, we might not see each other for another 3 months. I might see you in 3 months' time, and you'll be like, "Donnie, you look thinner. Must be the GLPs, right?" Like, we're gonna have this perception going on now of people like, did he try hard or is he on the drug? That's gonna be.
You mentioned the amount of hours in terms of the research that's been done.
Yeah.
Right. So, are these drugs going to improve? Are they going to get better?
That's kind of the trajectory, right? Like,
are there more generations that are?
I speak not on a position of power here, but I suppose, like every medication, in time they get refined, they become cheaper. We iron out some of the, and it's more on a side effect profile, iron out some of those unwanted effects as well. So I think things are looking up in the space. I think we can definitely help patients change their way of living, change their confidence, change their mental health. Most importantly, change their functionality. The better functioning you are because you've lost weight, I think the healthier you become.
Fantastic.
And maybe, just maybe, as you said, maybe the happier you become as well.
I think ultimately, healthy and happy is what we should all aim for.
Yeah.
So,
And that's what we as physicians really want for our patients.
thank you.
Thank you, Randall.